Paget's disease of bone is a chronic disorder that affects the normal bone remodeling process. In healthy bone, old bone tissue is gradually replaced by new bone tissue. In Paget's disease, this process is disrupted, leading to the formation of abnormal bone. The affected bones become enlarged, misshapen, and weaker than normal, making them more prone to fractures. Key features: abnormal bone remodeling, increased osteoclastic activity, bone resorption, followed by disorganized bone formation. Affected areas commonly affects the pelvis, skull, spine, and long bones of the legs. Symptoms: many people with Paget's disease are asymptomatic, but symptoms can include bone pain, joint pain due to arthritis in nearby joints, bone deformities, and an increased risk of fractures. Complications: severe cases may lead to hearing loss if the skull is affected, neurological complications due to spinal involvement, and, in rare cases, osteosarcoma, a type of bone cancer. Causes: the exact cause of Paget's disease is unknown, but both genetic and environmental factors are thought to play a role. A family history of the disease increases the risk of developing it. Diagnosis: X-rays often show characteristic bone changes, such as thickening and enlargement. Bone scan can reveal the extent and activity of the disease in various bones. Blood tests, elevated levels of alkaline phosphatase, an enzyme related to bone activity, can indicate Paget's disease. Treatment: medications. Bisphosphonates are the most common treatment, as they help regulate bone remodeling by inhibiting bone resorption. In some cases, calcitonin may also be used. Pain management. Analgesics and anti-inflammatory medications can help manage bone pain. Surgery may be necessary for severe deformities, fractures, or joint problems. Most individuals with Paget's disease can manage their symptoms and complications effectively with treatment, though ongoing monitoring is essential. Paget's disease can refer to different conditions depending on the affected tissue. Here are the main types. Hep 1. Paget's disease of bone, osteitis deformans. Description: a chronic bone disorder where the normal bone remodeling process is disrupted, leading to enlarged and misshapen bones. This is the most common form of Paget's disease and primarily affects the skeleton. Affected areas commonly involves the pelvis, spine, skull, and long bones of the legs. Symptoms: bone pain, deformities, fractures, and in severe cases, complications like hearing loss. 2. Paget's disease of the breast, Paget's disease of the nipple. Description: a rare form of breast cancer that typically starts in the ducts of the nipple and spreads to the surface of the nipple and areola. It often appears as eczema-like changes in the nipple. Symptoms: redness, crusting, or scaling of the nipple skin, nipple discharge, itching, and burning sensation. It may be associated with underlying breast cancer. Diagnosis: requires a biopsy to confirm, as it can be mistaken for dermatitis or other skin conditions. Treatment usually involves surgery, often a mastectomy, and may include radiation or chemotherapy depending on the extent of the disease. 3. Paget's disease of the vulva. Description: a rare form of cancer that affects the external female genitalia, vulva. It is similar to Paget's disease of the breast in that it affects the skin. Symptoms: red, scaly, itchy patches on the vulva that may resemble eczema or other skin conditions. It can be associated with underlying malignancies, such as vulvar or other genital cancers. Treatment: surgical excision is the primary treatment, sometimes followed by radiation therapy or chemotherapy. 4. Extramammary Paget's disease, EMPD. Description: this form of Paget's disease occurs outside the breast and affects areas with apocrine glands, such as the genital, perianal, or axillary, underarm regions. Like other forms, it presents as red, scaly lesions and can be associated with underlying malignancies. Symptoms: red, scaly, itchy patches on the affected skin, sometimes with ulceration. Treatment: surgical excision with follow-up care to manage potential recurrence or metastasis. Each type of Paget's disease requires a distinct approach to diagnosis and treatment, emphasizing the importance of specialized care based on the affected tissue and underlying pathology. Paget's disease of bone, also known as osteitis deformans, is a chronic condition characterized by the abnormal breakdown and formation of bone tissue. This can result in bones that are larger, weaker, and more susceptible to fractures. Here is a more detailed overview of Paget's disease of bone. Pathophysiology, bone remodeling process. Normally, bones are constantly being remodeled, a process where old bone is resorbed by cells called osteoclasts and replaced with new bone formed by cells called osteoblasts. In Paget's disease, there is an increase in osteoclastic activity, leading to excessive bone resorption. This is followed by increased osteoblastic activity, resulting in the formation of structurally abnormal and disorganized bone. Affected bone. The new bone is larger, but it is weaker and more prone to deformities and fractures. The bone structure becomes chaotic with a mixture of woven bone and lamellar bone rather than the normal organized structure. Symptoms and signs. Asymptomatic. Many individuals with Paget's disease do not exhibit any symptoms and may be diagnosed incidentally through x-rays or blood tests done for other reasons. Bone pain. The most common symptom, often described as a deep, aching pain in the affected bone. This pain may be worse at night and during rest. Bone deformities. Bones may become misshapen or enlarged, leading to bowing of the legs, skull enlargement, or other visible deformities. Fractures. Affected bones are more prone to fractures, which can occur even with minor trauma. Joint pain. Paget's disease can lead to secondary osteoarthritis in nearby joints due to the abnormal bone shape. Neurological complications. If the skull or spine is affected, the abnormal bone growth can compress nearby nerves, leading to symptoms such as hearing loss from skull involvement or nerve pain from spinal involvement. Commonly affected bones. Pelvis, the most frequently affected site, causing hip pain or altered gait. Skull, enlargement can cause headaches, hearing loss, or other cranial nerve issues. Spine, involvement can lead to back pain, nerve compression, and potentially spinal stenosis. Long bones, such as the femur or tibia, leading to bowing or deformities in the legs. Causes and risk factors, genetic factors. There is a strong genetic component, and Paget's disease often runs in families. Mutations in the SQSTM1 gene are commonly associated with familial cases of the disease. Environmental factors. Some studies suggest a possible link to viral infections, such as paramyxovirus, although this is not definitively proven. Age and gender. Paget's disease is more common in older adults, typically over 50, and is slightly more common in men than women. Geographic prevalence. It is more common in people of European descent, particularly in the UK, Australia, and New Zealand. It is less common in Asia and Africa. Diagnosis. X-rays, the most common diagnostic tool, revealing characteristic changes in bone size, shape, and structure. Bone scan, a nuclear imaging test that highlights areas of increased bone turnover, which can help identify the extent of the disease. Blood tests. Elevated levels of serum alkaline phosphatase, ALP, are commonly seen in Paget's disease due to increased bone turnover. Other markers of bone resorption, such as urinary hydroxyproline, may also be elevated. Bone biopsy, rarely needed, but may be performed if there is concern about possible malignancy, e.g., osteosarcoma. Treatment. Bisphosphonates. These are the primary treatment for Paget's disease. Bisphosphonates, such as alendronate, ristronate, or zoledronic acid, work by inhibiting osteoclasts, thereby reducing bone resorption and normalizing the bone remodeling process. These medications can help alleviate symptoms and prevent complications. Calcitonin. In cases where bisphosphonates are not tolerated, calcitonin may be used. It also inhibits bone resorption, but is less effective than bisphosphonates. Pain management. Analgesics and anti-inflammatory medications, e.g. NSAIDs, are often prescribed to manage bone pain. Surgery may be required for complications such as fractures, severe bone deformities, or arthritis that affects joint function. Surgical options may include joint replacement or corrective osteotomy, cutting and realigning bones. Complications. Fractures. Due to the weakened nature of the affected bones, fractures are a significant risk. Osteoarthritis. Bone deformities can lead to joint misalignment, resulting in secondary osteoarthritis. Hearing loss. Paget's disease affecting the skull can impinge on the auditory nerves, leading to hearing loss. Neurological issues. Compression of nerves due to bone overgrowth can cause various neurological symptoms, including pain, numbness, or weakness. Heart failure. In very severe cases, the increased blood flow to affected bones can strain the heart, potentially leading to heart failure. Osteosarcoma, a rare but serious complication, with a higher incidence in people with Paget's disease of bone than in the general population. Osteosarcoma usually presents with increased pain and swelling in the affected bone. Prognosis. With proper management, most people with Paget's disease of bone can live a normal life. The disease is typically slow to progress, and treatment can control symptoms and prevent complications in most cases. However, ongoing monitoring is important, especially for detecting complications early. Regular follow up with a healthcare provider, including blood tests and imaging studies, is essential to ensure that the disease remains under control. Denosumab, a monoclonal antibody that targets and inhibits RANKL, receptor activator of nuclear factor key B ligand, plays a role in the treatment of bone disorders, particularly osteoporosis and certain cancers affecting the bones. In the context of Paget's disease of bone, denosumab is not typically the first line treatment, but may be considered in specific scenarios. Mechanism of action: inhibition of RANKL. Denosumab works by inhibiting RANKL, a key factor in the formation, function, and survival of osteoclasts, the cells responsible for bone resorption. By blocking RANKL, denosumab reduces osteoclastic activity, leading to decreased bone resorption and potentially stabilizing or improving bone structure. Potential role in Paget's disease. 1. Alternative to bisphosphonates. Bisphosphonates are the standard treatment for Paget's disease because they effectively inhibit bone resorption. However, in cases where bisphosphonates are contraindicated, not tolerated, or ineffective, denosumab may be considered as an alternative. 2. Targeted therapy. Denosumab's ability to inhibit osteoclasts directly makes it a logical choice for managing conditions with excessive bone resorption, like Paget's disease. Some studies have explored its use in patients who have not responded well to bisphosphonates or who have complications such as renal impairment, where bisphosphonates are less safe. The 3. Renal safety. Unlike bisphosphonates, which are excreted via the kidneys and may accumulate in patients with renal impairment, denosumab is not renally cleared. This makes it a potentially safer option for patients with kidney problems, a common concern in older adults who are also more likely to have Paget's disease. 4. Effectiveness. Clinical experience with denosumab in Paget's disease is limited compared to its use in osteoporosis or bone metastases. However, studies suggest that denosumab may effectively reduce bone turnover markers and improve symptoms in Paget's disease, similar to its effect in other bone resorption disorders. Drawbacks and considerations. Rebound effect. One of the key concerns with denosumab is the potential for a rebound effect upon discontinuation. After stopping denosumab, there can be a rapid increase in bone turnover, leading to a higher risk of fractures, especially vertebral fractures. This rebound phenomenon needs to be carefully managed, which may involve transitioning to other therapies after denosumab is stopped. Cost and accessibility. Denosumab is generally more expensive than bisphosphonates, which can be a consideration in long-term management. Limited long-term data. While denosumab is widely used in other bone conditions, its long-term efficacy and safety in Paget's disease specifically are less well established. More research is needed to determine its role compared to traditional treatments like bisphosphonates. Conclusion. Denosumab may be considered as a treatment option in Paget's disease of bone, particularly in patients who are intolerant to bisphosphonates or have contraindications such as renal impairment. However, it is generally reserved for cases where bisphosphonates are not suitable, and careful monitoring is required to manage potential rebound effects upon discontinuation. Bisphosphonates are the cornerstone of treatment for Paget's disease of bone due to their effectiveness in inhibiting excessive bone resorption. These drugs reduce the activity of osteoclasts, the cells responsible for breaking down bone tissue, leading to a decrease in bone turnover and a stabilization or improvement in bone structure. Here's a detailed look at the role of bisphosphonates in managing Paget's disease. Mechanism of action. Osteoclast inhibition. Phosphonates bind to bone mineral surfaces, especially in areas of active bone remodeling. When osteoclasts attempt to resorb bone that contains bisphosphonates, the drug is taken up by the osteoclasts, leading to their apoptosis, cell death, or reduced activity. This decreases bone resorption and helps normalize bone over. Long-term action. Bisphosphonates have a long-term effect because they remain bound to the bone matrix, exerting their inhibitory effect on osteoclasts for extended periods even after treatment has stopped. Common bisphosphonates used in Paget's disease. 1. Zoledronic acid, reclassed. Administration, given as a single intravenous IV infusion, typically at a dose of 5 milligrams. Efficacy. Zoledronic acid is the most potent bisphosphonate available and has been shown to produce long-lasting remission in Paget's disease. A single infusion can normalize bone turnover markers for years. Advantages: rapid onset of action, high potency, and convenient dosing, once every several years in many cases. 2. Alendronate, Fosamax. Administration, taken orally, typically at a dose of 40 milligrams daily for 6 months. Efficacy, effective at reducing bone turnover and relieving symptoms of Paget's disease, though it may require longer treatment duration and more frequent dosing compared to IV bisphosphonates. Advantages: oral administration is convenient for patients who prefer not to have IV treatment. 3. Risdronate Actonel, administration, taken orally, usually at a dose of 30 milligrams daily for 2 months. Efficacy, similar to alendronate in terms of reducing bone turnover and providing symptom relief. Advantages: also available in oral form with a shorter treatment duration than alendronate. 4. Pamidronate, Aridia. Administration, given as an intravenous infusion, usually over multiple sessions. Efficacy: pamidronate is effective in controlling bone turnover, but it is less potent than zoledronic acid and requires more frequent administration. Advantages: useful for patients who cannot tolerate oral bisphosphonates. Benefits of bisphosphonate therapy. 1. Reduction in bone pain. Bisphosphonates significantly reduce bone pain associated with Paget's disease, which is often the most distressing symptom for patients. 2. Normalization of bone turnover. By inhibiting osteoclast activity, bisphosphonates normalize bone turnover, helping to reduce the risk of complications such as fractures, deformities, and arthritis. 3. Long-term remission. Especially with potent bisphosphonates like zoledronic acid, many patients achieve long-term remission, meaning they may not need additional treatment for several years. 4. Improvement in quality of life. Reduced symptoms and prevention of complications lead to a better quality of life for patients. Dosing and administration. Oral bisphosphonates should be taken with a full glass of water on an empty stomach, typically first thing in the morning. Patients must remain upright and avoid eating or drinking anything other than water for at least 30 to 60 minutes after taking the medication to reduce the risk of esophageal irritation. Intravenous bisphosphonates. IV formulations like zoledronic acid and pamidronate are administered in a clinical setting, typically over 15 minutes to a few hours depending on the drug. They are ideal for patients who have difficulty with oral bisphosphonates or require more rapid control of disease activity. Side effects. Intestinal issues. Oral bisphosphonates can cause esophagitis, gastric irritation, or ulcers. Patients are advised to take the medication with water and remain upright to reduce these risks. Acute phase reaction. IV bisphosphonates, especially zoledronic acid, can cause flu-like symptoms, fever, muscle aches, fatigue for a few days after the infusion. These reactions usually subside on their own. Hypocalcemia. Bisphosphonates can lower blood calcium levels, especially in patients with vitamin D deficiency or poor dietary calcium intake. Supplementation with calcium and vitamin D is often recommended during treatment. Osteonecrosis of the jaw, ONJ, a rare but serious side effect, typically associated with high doses of bisphosphonates used in cancer patients. The risk in Paget's disease is much lower, but patients undergoing dental procedures should inform their dentist if they are on bisphosphonate therapy. Atypical femoral fractures, another rare complication associated with long-term bisphosphonate use, characterized by unusual fractures in the femur. Monitoring and periodic reassessment are important for patients on long-term therapy. Monitoring and follow-up. Serum alkaline phosphatase, ALP. ALP levels are commonly monitored to assess the response to treatment. A significant reduction in ALP indicates successful suppression of bone turnover. Bone turnover markers, additional markers such as urinary hydroxyproline or serum C-telepeptide, CTX, may also be monitored to evaluate the disease's activity. Bone scans X-rays. Imaging studies may be repeated to assess changes in bone structure or the extent of disease activity over time. Duration of treatment. Single infusion, zoledronic acid. One infusion can lead to remission for several years, so repeat treatments may not be needed frequently. Oral bisphosphonates. These are typically taken for a few months at a time, with the treatment course repeated if symptoms return or if there is evidence of increased bone turnover. Long-term use. While bisphosphonates can be used long-term, treatment is often discontinued after remission is achieved, with careful monitoring for relapse. Conclusion. Bisphosphonates are highly effective in managing Paget's disease of bone by controlling excessive bone resorption, reducing pain, and preventing complications. Zoledronic acid, in particular, is a powerful option that can induce long-lasting remission with a single dose. However, the choice of bisphosphonate, administration method, and treatment duration should be tailored to the individual patient's needs, taking into account factors like tolerability, renal function, and the extent of disease activity. Regular follow-up is essential to monitor for side effects and ensure that the disease remains under control. Sir James Paget, 1814 to 1899, was a prominent English surgeon and pathologist who made significant contributions to the field of medicine. Paget is best known for describing Paget's disease of bone and Paget's disease of the breast, both of which bear his name in recognition of his discoveries. Background. Early life and career. James Paget was born in Great Yarmouth, England. He studied medicine at St. Bartholomew's Hospital in London and later became one of the most distinguished surgeons of his time. Paget was also a noted researcher, and his work laid the foundation for much of modern pathology. Contributions. Paget was one of the early advocates of the importance of microscopic examination in diagnosing disease. He contributed to the understanding of a wide range of conditions, including infectious diseases, cancer, and bone disorders. His meticulous observations and descriptions of diseases helped shape medical practice in the 19th century. Paget's disease of bone. First description. Paget first described the bone disorder that would later bear his name in an article published in 1877, titled On a Form of Chronic Inflammation of Bones, Osteitis Deformans. He observed patients with bone deformities, particularly in the skull, spine, and long bones, and noted that the affected bones were both enlarged and weakened. Paget hypothesized that the disease was related to a chronic inflammatory process, though modern understanding attributes the condition to abnormal bone remodeling rather than inflammation. Paget's disease of the breast. First description. In 1874, Paget described a form of breast cancer that affects the nipple and surrounding skin, now known as Paget's disease of the breast or Paget's disease of the nipple. He noted that this condition often presented as eczema-like changes to the nipple and that it was associated with underlying breast cancer in many cases. Legacy, eponymous diseases. The naming of these diseases after Sir James Paget reflects the significant impact of his work in identifying and describing them. His careful clinical observations and his ability to link symptoms with underlying pathological changes were pioneering for his time. As a result, Paget is often referred to as one of the founding fathers of modern pathology. Influence. Beyond the diseases named after him, Paget's contributions to medicine have had a lasting influence. He was knighted in 1871 and later served as a surgeon to Queen Victoria. Paget was also a prolific writer and educator, and many of his lectures and writings continue to be of historical interest. In summary, Paget's disease of bone and the breast are named in honor of Sir James Paget, whose detailed observations and descriptions of these conditions were key to their identification and understanding in the medical community.